So good morning, everyone. We're going to get started slowly. It's Friday morning. Yes, it's Friday morning. We made it to Friday morning. We made it here after being out till 2 in the morning. I'm Catherine Staton. I'm a Vice Chief of Faculty Development and researcher focusing on global health, innovation, and implementation science. I'm the co-director of the Gemini Center, which is Global Emergency Medicine Implementation and Innovation Research Center, so you know why we shortened it. It is a mouthful. And I work both at the Duke University as well as at the Duke Global Health Institute. I am here to really introduce them to talk about really the cool stuff and ask some cool questions, hopefully with you guys. So first up, we have Dr. Anjani Joyner. She's an assistant professor of emergency medicine at Duke University, and she serves as assistant medical director for Durham County EMS in Durham, North Carolina. Her research focuses on pre-hospital and emergency care development, low and middle income countries, and injury prevention. Most of her work is in Brazil, Tanzania, and Southeast Asia. Next up, we have Brian Rice. Dr. Rice is a clinical associate professor in the Department of Emergency Medicine at the Stanford University School of Medicine, way out on the other coast. His research work is in clinical epidemiology, and he's focused on outcomes for emergency medicine in low and middle income countries, specifically with a focus on task sharing and chief complaints. His current research focus is using ML models to provide clinical decision support for medevac utilization and non-physicians in rural Alaska Native American communities. I can't wait to go visit Alaska. I'm coming, by the way. Dr. João Visoshi is an assistant professor at Duke University, also in the division soon to be Department of Emergency Medicine. He is the co-founder of the Gemini Center with me, so obviously we never worked together. He's clinically a psychologist with a PhD in social psychology, and his research interests are incredibly broad. Research methods, innovation, applied methodology to understanding access and quality of care, primary care, global mental health, pretty much all of it. He works actively in Brazil, looking into population health and health systems, as well as Tanzania and Uganda, focusing on traumatic brain injury and clinical trials. So as I said, incredibly broad. And finally, we have Dalton Costa, who is a psychologist. He graduated from the Federal University of Health Sciences in Porto Alegre. So please welcome him. He is currently a research assistant at the University of North Carolina at Greensboro. His primary focus is on the cognitive assessment of the elderly, and he has recently been working on research involving the use of virtual reality and training of public safety professionals in the United States. Incredibly cool, working on some VR stuff. We're here today to talk a lot about artificial intelligence and how that works in low and middle income settings. Having a little bit of understanding who we are, hopefully will give you some information about how we work within this scene. My job is to be quiet and let them talk now that I've done my thing, and then help you guys ask some questions at the end. And we are going to start off with Dr. Visoshi to start talking about how artificial intelligence is used in low and middle income countries. You can join up here or you can sit there, it's up to you.
Thank you, Catherine, for the introduction. Thanks for everybody who survived Friday and is here to listen to us. And I'll start up this didactic by giving a more overview of the kind of work that we do. We do, as you saw from our background, we do not want to exhaust as specialists in artificial intelligence, because this is part of what our team does. We're trying to talk about its application to low and middle income countries. So I don't have any intention of giving a class about artificial intelligence, so what it is. At the same time, we're not trying to exhaust all the possibilities that artificial intelligence can do, but we just want to bring up the enthusiasm about bringing this as a solution to low-resourced or low and middle-income countries. So that's what our goal is. Some disclosures, some of the funding that's been associated with the work that we do. And so I'll do a brief introduction, and then I'll jump into some applications, and then we'll have our colleagues here show some of the actual work that we're doing. But to kind of guide our thought on this presentation, we're defining AI, artificial intelligence, as the theory and development of computer systems able to perform tasks that normally require human intelligence, such as visual perception, speech recognition, decision-making, translation between languages, and others. So it's when you try to teach a system to take up some functions and try to act as where a human would need to act, especially in tasks that can be transformed into computer or probabilistic thinking. A couple of examples here. I brought here cars because I didn't want to show intelligent cars, but we're driving towards having automation applied to a bunch of different things. But at the same time, we're trying to apply better use of technology to speed processes can become burdensome, such as chatbots, which I hate, by the way. So these are a couple of applications. But when you think about low and middle income countries, it's a little bit different. A couple of related terms when you think about artificial intelligence are machine learning and the concept of supervised, unsupervised learning, predictive modeling. These are parts of areas that are around this concept of artificial intelligence, this area of science of artificial intelligence. Deep learning, reinforcement learning, active inference. So these are all types of methodologies applied within an artificial intelligence framework that doesn't necessarily need to be all of this predictive probabilistic modeling, but these are what is in everybody's talk currently, who got to acknowledge that. But there are other ways to apply that as well. So continue on this concept of what is AI. So basically we're trying to teach a computer, we're trying to teach a system to make decisions and to interact. This could be a very simple interaction such as, here's my data, tell me what to do. Or it could be a more complex interaction where you continuously keep data, you let the system improve their knowledge, and then you get better decisions and better suggestions. But in the end, it's always going to provide you some response. So this can be applied to a myriad of different types of data. And this is an example that I have here put out, which is our study where we are developing a system that can support planning for resource allocation for healthcare resources. This was applied to vaccination because we wanted to jump the hype of COVID and get some publications, but we're mostly applying this to other preventive techniques in low-resourced areas, such as medication distribution or planning for vaccination, but in other areas, especially in Brazil, but also in Tanzania. But the example here is that what we are doing to build this technology is that we're using different layers of data. So we're using EHR system, which is understood as structured data. So data that comes in, well, I was going to say beautifully and clean, but that's not true. It comes in noisy, but it comes in numbers. So you can actually understand it a little bit better than if it comes unstructured, which is a group of text or an audio or a video or a photo that it's a little harder to interpret for a computer. So you have to transcribe that into numbers, and then the computer will be able to understand. So in this study, we are using different sources of data to exemplify what we can do. So structured data from EHR of places where people are suffering from a given disease, in this case COVID, but in other cases snake bite envenomation. We're also using satellite imagery to decode the image and understand where people live by looking at where constructed villages are in a resource setting. So in this particular study case, we're looking at the Amazon forest, and we're trying to identify within that big space of forest, where are the actual villages, so that we can transpose population density to specific locations within a large geographical region, and then maybe estimate better distances to care, better barriers to care. We're also using layers of healthcare facility information that basically comes in as where facilities are, and then combining that information with road network infrastructure data, river data, we can combine this information and create a machine that now can see, well, here is where people live, here is where healthcare resources are, here's how people have to travel to get to healthcare resources. So thinking about this and thinking about either maximizing coverage or maximizing efficacy of a treatment, we can put treatment in these particular locations, and then secretaries of health can make their planning for budgetary reasons. So this is one of the potential applications that changes over time according to the epidemiology of the disease and the way that treatment is offered with different sides of data. So transposing to what I'm saying, there's two ways of understanding this. There is what I was saying about probabilistic and non-probabilistic teaching for artificial intelligence. So one of them, which is more like the hardcore programming we are familiar with, we're trying to teach a system, which is the box in the middle, roles and some data so the system can tell us what's going on. So I'm telling the system, if you get X number, give me this solution. In other types, and then this is a couple of programming things that I put here just to try to show that I know how to do this, but that's not necessarily true. The other example is where you bring in the actual answer you want, you bring in the data, and you ask the computer to give you the rules, and then to react upon these rules. And that's where you're trying to teach the machine to think. And that's more on the probabilistic machine learning approach. So that, from how most people think AI and machine learning and all of these areas is, and I've listened to a lot of the people talking about this, is this black box method, where you have some data, it comes in into this black box, there's some magic going on, and then it spits out a robot. It spits out a driving car or something like that. But in practice and in reality, what you really need is a very good question to answer. I know yesterday I saw some news about the AI that will take over everything, a deep mind and everything, which is pretty cool. But I'll tell you, from our experience with working with these predefined algorithms, they are not very precise for particular questions. And what we've learned by trying to do very generalistic AI models that try to answer very broad questions, such as which patients need to be admitted to the hospital, these AI models have some accuracy, but they won't go to the further detail of stratifying the risk for particular use cases, which are more meaningful for physicians or healthcare professionals, instead of just telling me if a patient needs to be admitted or not, because I'm pretty sure you can do that by eyesight, right? So I think you really need a good question, and that question needs good data, and that's a problem. We don't do AI on anything, because then bad data, bad model. You need a very good theory behind it to be able to build a machine that makes sense. And you need more data to then build it up. And you need to think about some things that are not very important, such as ethics, equity, and all these kinds of things. So all of these have to come when you're planning it out, when you're designing what this is going to be. Then it goes into the black box that I'll tell you, it's not a black box. It has a set of very widely used techniques and statistics that are very well known with their limitations. So it's just not because I have deep learning, I'll throw it in there, it answers everything. That's not true. Especially if you have a shorter amount of data in what we usually see in our EHRs or our registries in low-middle income countries. Deep learning won't solve those problems. You need experts in modeling. You need a lot of experts in modeling. You have to try it several times until you figure out a model that does make sense, and it brings in a lot of frustration. That's what's inside the black box. And then it does spit out a robot, but it spits out a robot that's full of flaws that we need to fully comprehend to be able to understand its application and really translate it into something that is clinically meaningful. So it's not a black box. And then jumping to close, why apply this to LMICs then? That's the question I always get when I'm trying to talk to people. Why are you going to try to take artificial intelligence to a place that people need food? And that kind of question. And what I always tell them when they say, you can't do it because there's no data. And I say, well, have you gone to these countries and asked them what kind of data they have? There's a lot of data out there. This is an example of a study we do in Brazil. Brazil, for instance, has huge amounts of healthcare data, nationalized data that covers the entire countries, billions and billions of healthcare encounters. And when you look at that data, it's freely available for you to explore. If you go to Tanzania, there's a myriad of research studies that collected 50,000, 100,000 patients for many years that are sitting there, and they need to be leveraged, reutilized. And so there is data. You just have to make the right contacts and partnerships to use it. Then they say, well, there's no capacity for it. Well, capacity was an issue. It's not anymore, because now we have a very wide, broad description of cloud computing, of internet modeling, and then we can take artificial intelligence to remote spaces by different means, such as SMS texts. such as handheld devices, such as small computers that you can hold in your hands. So we do have capacity in a low cost to bring the solutions to these countries. And so I also need to bring food, but I can bring all the intelligence around deciding how to better distribute this so I can reach more people, so I can be more effective and take whatever we've learned in other scenarios to expand their capacity there, which is already limited. This is an example of something we did in Brazil for remote areas, trying to improve our capacity to identify women with high risk for negative birth outcomes. And that is done at the basic health unit center. And then when they identify a woman with very low training, they can then link them up to higher care resources. And so by the end, the why, I think, and I deeply think that this is an area of interest and an area that we need to grow in this world of global health, is that we can use technology to bridge the gap in healthcare between LMICs, so low and middle income countries, and high income countries, using advanced technology and analytics. We can optimize resource allocation, we can address the lack of local experts and the time it takes to train people, we can promote equity in access to care, and it can improve quality of care as well. And so you'll see a couple of examples trying to show how we can apply this to structured and unstructured data. But as I said, it's a goal to motivate us to think about this in these low resource settings. So thank you.
So, first of all, thank you for our audience to stay today so early. So, I'm Dalton. I come from Brazil, and currently I'm research assistant at the University of North Carolina at Greensboro, and I have a partnership with Professor João and Gemini. It's a global health institute at Duke, and there we have been developing research regarding how to assist healthcare professionals in low and middle income countries. And we have figured out some results, like the one key important for help these professionals is work with data science. In data science especially, we have different kind of data, as Professor John said. For example, structured data. That's kind of, I will discuss a little bit today. It's a little bit different, my slides today, but yeah, we changed a lot, sorry. But structured data, we have producing a lot of all days. All days we produce in structured data, such as when you fill out a form and you click on button, and we produce structured data. But the main characteristics of structured data is when you can put this data in a table, for example, and rows and columns. And if you have a table, you can do analysis, and you can build graphs, you can figure out some results, you can help people with them. In clinical field, it's not different. In hospitals, we produce data a lot all days. When we fill out the system of the hospital with patient information, we have structured data and unstructured data as well. But it's common in the hospital, we have a lot of data, and the hospital needs to manage this data. For example, hospital sometimes is required to create a management system for data. And then it's complicated because where this data is there in the cloud? Who have access to this data? Just the directors. But this data is very good for us to work with people in low and middle income countries. Especially because in these countries, we don't have resources enough to do our work. And sometimes we need to do right decision. But if you want to do the right decision, you need resources. it's not working if you don't have resources and we don't have the information on your hand. So this information is stored in the cloud, maybe can help this professional. This is the idea. So one question we have at Duke, it is, how can secondary data assist health professionals in make complex decisions in low and middle income countries? So, in my opinion, and how Professor João says, artificial intelligence can help literally us in this, solve these problems. Especially machine learning can help to create tools to help health professionals to make decisions in emergency care. So I'd like to share with you two experience of Duke on the Tanzania. The first project, it's about how can we predict short-term in-hospital mortality risk of children. And the project two is how can data-driven optimization assist professionals in decision-making for patients transfers to specialized traumatic brain injury TBI care. So for the first project, we talk about the PRESTO model, especially because the low resources on these countries, some researchers create this model. The name is PRESTO, is Pediatric Resuscitation and Trauma Outcome Model. The goal is predict short-term mortality using initial patient assessment variables appropriate for and available in low resources settings, using variables like age, hypotension, heart rate, saturation, need for supplemental oxygen, and neurological status. And we build a model following the same steps from the original model PRESTO. It's come from the United States, and we apply in Tanzania using the same variable, the same path. And we got 400 patients on Tanzania with 7 years old in median. Most of them were male, and the main reason to trauma was traffic accident. And in our data set, we got in hospital mortality 7%. And we got a good results, especially because besides we have few participants, we got some similar results from the original model from the United States. Especially you can see for AUC and specificity. So this is the first validation model for Tanzania. And despite of the number of the participants, our preliminary results show good predictive potential. That is, the model can discriminate who is dying or not in short term. And of course, we need to study more this model and expand this model for another population and study this math makes sense for this field. About the second project, it's about trauma brain injury. We would like to answer the question how to support data-driven optimization of patient transfer for TBI specialist care, especially in low and middle-income countries, where access, infrastructures, and personnel are scarce. How we can help professionals to make decisions in a TBI emergency when we have a few resources available. So again, machine learning can help professionals. And we developed some models for this final. And we create a model. Actually, we tested a lot of models, and we got the best one. Is the Bayesian generalized linear model, and it's able to predict the prognosis of the patient. We built this model using more than 3,000 patients from Tanzania too, using variables such as demographic information, vital signs. And for AUC of this model is 0.87. And this paper, this result has been published in this paper. And besides, in addition this this model, we build a tool, and we discuss how to create tools and how to use this model in the practice, how professionals can use this in daily. For the conclusion, the development of TBI prognosis model with substantial level of accuracy in a low resource setting. Of course, we need to do external validation this model as well. And of course, this kind of solution can help professionals make more rational clinical decisions. That's it.
Yeah, it doesn't go together.
We need to walk up slow-mo. Hi all, I'm Anjani Joyner, and
Brian Rice.
So we're going to talk a little bit about unstructured data. So I wanted to start with a couple of case studies. So I wanted to talk about my experience as a young global health researcher starting out shortly after graduating from residency. So I was introduced to the country of Eswatini from a colleague of mine, and came up with a project during my master's program to look at the impact of drought on EMS services. And so I was interested in seeing what types of complaints and how the types of chief complaints changed during this massive drought in the region. So I got IRB approval from my local university, I got local IRB approval, I got approval from in-country leadership, and then finally obtained the data, and this is what I got. I was like, what am I supposed to do with this? So this is an example of unstructured data. So this is our chief complaint data from their emergency call center. And as you can see, I looked at this and my first thought was, I don't know how I'm supposed to categorize these calls other than manually going through 130,000 complaints. So I quickly realized that I was going to need a different approach to categorize these chief complaints into usable categories. So a little bit of an introduction to unstructured data and LMICs. So the most common way that we encounter these data are usually in the text format. So this could either be paper-based or electronic. And we commonly see this with chief complaints. And this has been, capturing and analyzing chief complaints has been made a priority for EM research in low and middle income countries. We also less often see this data in audio format. Typically, this is more in emergency call data to emergency call centers, although that's less common in some low resource settings, but we can encounter it in some areas. So what questions can be answered through leveraging unstructured data, and how do we create structured, usable data from these sources? So back to case study number 1. So initially looking at this data set, we can see some of the challenges with building a model from this data. So we can see many irregularities, including numbers, symbols, abbreviations, and medical terminology, which makes this more challenging because this isn't natural language. This isn't how we normally speak to each other. So it requires kind of a different approach to determine how to make this data into something usable. So we ended up applying a multi-step process, starting with data cleaning, followed by tokenization, which is identifying the root word in each sentence, and then applied latent semantic analysis to weigh each of the chief complaints, or each of the words, and then group them together to create essentially a word cloud for similar chief complaints. And this is an example of what we came up with. So basically, by weighting and grouping each of the words within a chief complaint, we were able to create clusters, and then these clusters ended up representing chief complaint categories. Case study number 2.
This one's also about our painful pet passion project of chief complaints, and hopefully I can explain a little bit about why we care about that. This is a different data set that also is an unintentional, unstructured data set. So this comes from an NGO called Global Emergency Care, which has been in rural Uganda since 2009, focusing on training up non-physicians to provide emergency care in low-resource settings. Basically, since 2009, we've been building up this registry data, looking at these patients, and and again, the quality of this data is similar to what we had with the other one. Misspellings, abbreviations, local abbreviations, that's difficulty in breathing, dizziness, vomiting. We have multiple chief complaints in a single line with various different things that are different tokens to represent the different objects. We have British spellings, and some locally important things like drunk paraffin, which would be a suicide attempt in a rural area. And so what we wanted to do from this is kind of the flip side of what the automatic tokenization part that they were doing in Eswatini was, and try to classify these things and why, just as a plug, do we care about chief complaints in these regions. So in these areas where there's almost no structured data, where there's almost no diagnostic technology, and where clinical diagnoses vary widely from facility to facility within a kilometer of each other, the chief complaint and the patient's statement of what's going on takes on this outsized importance. And the idea of us exporting what someone, sort of the chief complaint system and what's like a high-risk chief complaint in the US, transporting that to these regions seems kind of inappropriate, because this is largely unsullied data. This represents what someone who speaks local Rankori would say to a nurse who is fluent in both Rankori and standard British English, what they'd write down on a piece of paper, right? And so what they say that then corresponds to what their outcomes are is actually an incredibly important thing. And so what we did was, if you remember Joao's first slide of the painful, old-fashioned programming procedural stuff, that's what these different tiers are. We got these 40,000 chief complaints from 30,000 patients, and then using brutal, old-fashioned programming methods that may date back to 1984, when I had to teach myself to program because I didn't have friends to play pencil and paper Dungeons and Dragons with. That's a true story. So we basically hacked these things down to the point where we only had to hand review thousands of charts amongst US-based experts and local clinicians instead of tens of thousands. But what we were able to do is we were able to develop this coding system or ontology that would take the things that were being taken without any reference to billing codes, to epic drop-downs, to just what they were saying, to build up from like a bottom-up data-driven approach, these 83 chief complaints, and that represent over 98% of all the visits, and there's actually 23 that represent over 85, which then would be appropriate to put on a single piece of paper if you're trying to make like a T-sheet for use in one of these areas. And again, this is all just based on what people have been saying to build the categories from that, right? I hope that makes sense, because that's like 7 years of my life. And then why is this interesting? What does this mean? Was this all worth it? So this is the next step of it. So basically, like, if we take these chief complaints, and the hypothesis we're testing is that these will predict short-term mortality. If you say certain things are going to happen to you when you control for the other data that's available, which is just vital signs. So, right, vital signs plus what they say at triage, does this alone predict short-term mortality? Can we generate an actual data-driven high-risk chief complaint that has nothing to do with medical legal things, that has nothing to do with resource utilization, the way we talk about chief complaints that are high-risk in the States, but just, will you die? And the first question is, can we do it? And yes. So this uses kiddie pool and machine learning models, multiple variable logistic regression, and it shows that you can have, and the way the algorithm works, no matter what low-risk things you say, if you say a high-risk thing, that's what gives you your highest level of risk. And then if you say something high-risk, you have a 400% increase in short-term mortality. If you say only low-risk things, you have an approximately similar reduction in your short-term mortality. And I think the other question that we really weren't sure about was, would this give us anything useful, right? Because we already have the WHO saying if someone is unresponsive or they're short of breath, that they should be highest triage category, and I didn't need to spend 10,000 hours to say that. And so those things are in fact high risk. But we do see some other things that we weren't necessarily expecting, like abdominal distension. If you walk in for 3 days from rural Ugandan bush to a medical facility with abdominal distension, you are going to die because you have a high-grade bowel obstruction. Interestingly, that it came like 2 cases below our threshold for rarity to put on here was hiccups. Hiccups is the worst thing that you can come in and say that you have. There was some stuff from the early Ebola outbreak that also said that hiccups had really high mortality, and if anyone wants to talk about hiccups in the next session, we totally can. And then other things which don't predict high risk, chest pain, that's interesting because, if you look at your walls and your EDs, it says, tell the nurse if you have chest pain and want to be more important than other people and not wait as long, and it doesn't mean as much here. And then other things I think that were interesting, if you have head injury or a road traffic accident without any other associated symptoms, you are not at a higher category. So the idea is that we have now taken something using only the data that they have, using nothing else other than did they die and what were their triage vitals that could help generate a locally appropriate data-enriched triage categorization thing, which takes us to the next question of how do we combine these two, and when we have the not-so-black box try to do the same task, and we now have this manual version of it, how do those things work together, because we can then theoretically build a pipeline where taking this from any region in any language, we can tokenize, develop what their local chief complaints are, and help them build the system, again, using only this available registry data, which would be pretty cool. And then this is the challenges, which is going to set us into the questions stuff.
Yeah, we'll start with some questions.
Yes.
Excellent. Good job. So we're going to start with some questions, but before we start, I actually want to ask each of our panelists to tell us a little bit about the challenges, because as we think about doing AI in a low and middle income setting, my mind is blown in terms of all of the roadblocks we're going to hit. So if you can think about from your presentation, of course, integrate some of these as well. Can you give an example of a challenge and what are the possible ways of overcoming it? I think there's a microphone there. Or did I just baffle you so much? None of you want to answer? We never overcame them. We never published it.
Well, I think a couple of the reasons to why I think it's important to do is also the challenges. So there's data, but this data is not in a good shape, not just in terms of quality, because I think there's good quality to get out of this. It's just that they're not standard and ready for you. There's not an epic system that will throw it out for you to use. You have to go and you have to build standards. You have to do a lot of organization. You have to think about the data processes. So all the work we've shown has a myriad of data management and linkage and connection that goes without saying, and that I think is the biggest challenge. But it's also, for me, it's fascinating because it's something that we can actually solve. And then some of the other challenges they can talk about, I think, is just the literacy and getting people to be more used to technology in a space where technology is not really there. So we need to put this into training. So it's not the computer side of things that are the challenges. It's how you get this there. And it's a culture thing. It's an access thing. It's an equity thing that we can easily solve. And that's what I think is the main challenges.
So one of the challenges that we've come across in doing our work in Brazil is language. So a lot of the proprietary software like Siri, Alexa, those audio transcription models are not meant for Portuguese. And so that's something that we had to develop. Dalton had to develop from scratch. And so that... So that really is a time-consuming process, and it's another layer that we have to add on to any project that we're doing.
I think one of the ones that I wasn't really expecting to run into, as a lot of the stuff that I had focused on was the technical side. I'm little bit of a nerd. One of the problems I think is also the data sovereignty and the data ownership, and also some of the political, political is not the right word, but like the cultural feelings about what AI means. Like even within my organization, GEC, when I talked about engaging in this project, at least one of the board members on it was like, full stop, no, we're not going to feed data to this black box, and it's going to get turned, like this idea that it would somehow turn into like marketing data rather than tokenization of like syntactic vectors. And I think that that's been a real challenge, and also at the bringing that to like ministry levels where there aren't even agreements about data sharing, and like the code that we use, we can't put open source because that doesn't exist within the Ugandan government. And there's a lot of these like sort of there's the technical parts of it are hindered by a lot of these administrative things, and those are really hard conversations to push forward. And I appreciate that there is this growing feeling about data sovereignty and ownership from these regions, and that's something I want to support and maintain. But how to like integrate with that has been really challenging, and I don't actually have a great solution to it yet. But I think that as the work scales up and it happens in more regions, that hopefully some of the bias against these methods and models will help make those conversations easier.
That's a great response. I have
Thanks.
a million more questions for them because I love picking their brains, but I wanted to see if you guys had more questions. Yes, please.
Awesome talk. So I have been starting to do machine learning and wearable devices for sepsis prediction in Bangladesh, but one of the ways we do that is we partner with a data analytics startup company that does a lot of fancy stuff, but then we're running into an issue where like they're a for-profit startup company. We obviously don't want this to be a for-profit driven initiative. So how do you develop like local expertise, especially being a clinician? Like I don't know how many years you spent developing all of this expertise. Like how do you, like what's the best and most efficient way to develop this, or is the answer just to be a clinician and partner with someone? And then my second question is, how do you develop this expertise globally? Like in Bangladesh, my collaborators really want to learn these fancy things like as much as I do, but like how do you start developing that in places where you take off a few years to do a master's program?
Great question. I'm just going to repeat it for the audio. The question is, how do you develop local expertise here in terms of who we collaborate with at our universities, institutions, and how do we do that in our partner countries?
I'll give you my thoughts. They're probably not the right ones. But so I think that in the global health arena, even if we want to do things that are going to be sustainable using the for-profit model, they need to be at the location and not here. And I think that that's a big problem. There are models that some startups use that they are going to build something and they're going to offer it for a lower cost at lower income settings that could function. But in the end, as what Brian is saying, I think that we have to talk a lot about ownership and what that's going to bring back to these countries. But again, it's probably not the right answer for some people. The other thing that I think about, again, from a research perspective, our goal is to build capacity and reduce inequities. And so I think that building the device and building the algorithm is cool, and then you catch some pretty pictures and things happening, which I think is great. But a research program should incorporate the training. So I think we should have more D43s, more K awards, more grants for local partners to build their local champions on the thing and then get them to be up to speed. So that's why we have Dalton as an example, myself as an example, that come from a country that spent time learning this with opportunities. And I think that that should be thought out as beyond building the device or building the robot and everything like that. So that should be part of the planning to build that capacity, as my understanding.
So to answer a couple of the other parts of the question, this is just sort of a plug for early mid-career clinician researchers. Like you should not be, you asked like what you should do in particular, and this is sort of like a general that your importance to it is not in going to be actually like writing the code, and the masters that you would go off and get is to like be able to sit at a table and have a conversation with the people that were writing the code, and that you as the Rosetta Stone that can identify interesting clinical questions is something that you shouldn't overlook. And I think that those of us that have a clinical background take that clinical knowledge sort of for granted and don't realize how incredibly important it is to be able to formulate the questions and interpret the data, and that's part of what the actual black boxes are. Like, you're a big chunk of it, but it's not the writing the fancy code that Joao put on to impress us all. And so that really is an incredibly important role and takes a whole career to fill that. Who you're communicating with, those specialists, it is unfortunate. It seems like a lot of those live in the private sector rather than I was going to say the public sector, but I don't know. I think that I'm probably skeptical enough about, no one's recording this, right? Universities and their proprietary and, like they are for-profit in their own ways. Like, we're not necessarily good guys. We collaborate differently and try to steal different things from folks for our own perverse incentives. Sorry. But I think that so one of the things that I think is the key to going forward with this, when these resources are pretty limited, some of it has got to be collaboration, and that having every different university develop their own set of 4 people that can then collaborate with 2 or 3 other private facilities to generate enough capacity to answer questions in a single location. Like, having that redundancy doesn't help. Getting around that redundancy, again, it's really tough to crack the silos of universities. It's really tough to get collaboration between these things, and I think that that sort of has been the heart of what a lot of global health research has been trying to break those silos, and I think that that's one of the ways to get it. But I think that having clinicians that can help identify the questions, working with the local experts, with a sort of access to people who have the technical capacity that can then communicate with that, and that's probably going to end up being some conglomeration of academic and private things for the next decade that I can sort of imagine it. And again, another plug for like the Fogarty training grants and things like that can help train one of those people to then become the local leader, and sort of appreciate that there is this lag time, that if people who already have that expertise are showing up to work on that problem, getting that person to the speed where they can then lead that project is not feasible, though desirable, and sort of how to negotiate that from the beginning and have that understanding that like this expertise is showing up. We want to build that expertise here, but that's been one of the things that the challenges that we faced over the last 13 years in this region, as people are like, oh, the emergency care is great, we want to be doing these things, but then how to have some equity in how you're doing the training, providing the care, and answering the questions, because those are all sort of different time frames, if that makes sense.
Other questions? Yes, please.
I'm sorry, I missed the very beginning of the talk, so you guys may have covered this. My question relates to an experience that I've had in a low resources emergency department, or a moderate resource emergency department, that wanted to see the promise of AI for their triage protocol. They've previously been using South African and weren't tremendously happy with it. There was an AI-driven algorithm they identified as one of their major problems, that they felt like South African
Yeah, so I think that the argument I was making in the beginning is that I don't think it should be understood as a black box to start. And I think that's probably what caused a lot of these issues. You have to fully understand the data. It's different when you're building an artificial intelligence to tell you which device to buy on Instagram, because there's no risk. So when we bring this into the medical field, into any field that has decision across people's lives and treatment and options, these things need to be tested. So there's a lot of discussion in the field that AI algorithms should be understood as treatment options, and they should be treated as such for the evidence level we accept before implementing things. And I say that because, to be very honest with you, any graduate student, undergraduate student will be able to build AI models very soon, very soon. And that's the case right now. So, and then a bunch of students are going to come together, build a company, start making their models and put it out there. If we don't put rules or some level of evidence to accept something to be implemented, we'll be facing those issues very well. So there's a lot that goes into understanding the model, and that's why I don't like the black box concept, because it's not a black box. And there's a lot that go in understanding what is it that the model is giving you, how the model is estimating those effects, how the model is performing with several metrics that is not just AUC. So you have to look at the model and where the model is making mistakes. There's a lot of work that needs to be done on the quality of the bias, or on the quality and the bias of the data that are feeding these model decisions. So I think that's what is going to halt this expectation around AI in health, and I think it's important. There's some folks at Duke that have argued that every AI model needs to come with, what's the name of the thing you guys put on a medication sheet that has all the evidence? What's the name of that thing? We say bula in Portuguese. I don't know what is it in English.
We'll go with that.
Okay.
That sounds
Well, I was going to make an analogy, but obviously don't lack the English knowledge for it. But it's basically every AI device, algorithm, robot, whatever you want to call it, needs to come with a sheet that says these are the accuracy, this is the calibration, this is how it performed in this and that clinical study, this is the known flaws of this model, this is how it should be used. Because the other thing is, I'll be talking forever if you guys want to say something.
I just added some additional information. For example, in machine learning, you have autopsy of the model. And then you can figure out exactly what happened for the prediction to be that one. For example, autopsy for image classification, you can see exactly which pixel is the most important for that decision and the why. And for example, for structured data, on decision tree, you can print a tree decision for you can understand exactly what happened. So the black box it don't make sense sometimes. And I think it's important validation of the model every time. It's one thing, it's you training your model on your home. When you go to hospital, it's not working because the real data is different every time. You need to train, retrain. In each local have specific characteristics you need to train and specialize the model either. Yeah.
All right, and sort of to dovetail on those, that there are, these reporting standards for transparency in AI, like the Minimar, and that's actually with some of being pushed by some of the people that I'm actually training with at Stanford, and it's cool to hear it come up in conversation. And one of the ideas is that not only do you need to say what the bias of your models is, but also understand that every data that you work with is in itself inherently biased. And one of the things that we can see is that when we build the machine from this data that we have been categorically underrepresenting the emergency needs of women, it gives us a biased output, and that there are also the role for the experts in the gray box that is not the black box. That when you go through these things and you're looking at the system, you have the local expertise, a plug for your being a clinician researcher who understands like the clinical importance of these things, where you're like, oh, there are we actually need to add in some procedural rule sets into this where there are these, do not pass go stop points, where if these red flags show up, that it circumvents these things, and a machine, depending on the data that you're feeding, it won't see those things in quite the same light that a clinician would, and so that's why you need to have these clinical experts that are involved in the development of the algorithms for identifying which of these outcomes are irrational, and also that sometimes it's the basis. One more plug for locally specific ontologies. If they're saying difficulty in walking, and that in fact is what cardiovascular collapse is described as. If it's not a locally trained system, they won't appreciate that that is a terrifying thing to say, and then systematically underrepresent that as well.
So I think we could talk for years about this topic, but we've come to time. So thank you so much for coming this morning, as well as asking excellent questions. We obviously will be free afterwards, and you can always touch base with us by email if you have more questions. Thank you.